Welcome back to the next section of neonatal resuscitation. So let's review very quickly. Prior to the delivery, we asked the 4 questions. We put the baby under the radiant warmer, and if we suction, we used a 10 or 12 French suction catheter. We've used free flow oxygen at 10 liters per minute at 30%. And we've started PPV because the baby didn't respond, using 21% for 35 weeks or greater and 21 to 30% under 35 weeks gestation at a flow rate of 10 liters per minute. We've administered the breaths at the right rate. We've started our peak inspiratory pressure between 20 and 25 centimeters of water, and the PPV is not rising the heart rate. We've reassessed. We've checked our Mr. SOPA. The heart rate is still not rising. So now we go on to the next level of neonatal resuscitation. So the heart rate continues to be below 100 beats per minute. So now what do? Of course, we check the chest movement, make sure that the ventilations are adequate and that the chest is rising. And now the last step of the Mr. SOPA, shown up here, is to consider an alternative airway. Let's look at our equipment. I told you before, you can use a small towel, roll it up, and put it under the baby's shoulder. What this does is it ensures that the baby is not underflexed or hyperflexed. It also protects the back of the occiput of the baby. So we go in. I'm going to go in with my left hand. So my dominant hand is free. Visualize the cords. We need to make sure that we're not putting too much pressure on the baby's forehead. And go ahead and insert my tube. If my tube is not in the right place, I will not have expansion of the chest. Once I have my ET tube in, I'm going to check to see if I have rise and fall of the chest, and as you see, I do. I also can check placement by testing it with a CO2 detector. So go ahead and put my CO2 detector on. Continue. Breathe, 2, 3, breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. It may take 6 to 10 breaths before the color change happens on the CO2 detector. In fact, if the baby is not oxygenating well at all, it may take even longer than that. We have considered inserting an ET tube or a laryngeal tube, and after assessing the heart rate, again, the heart rate on the baby is less than 60 beats per minute. We certainly need to make sure at this point that we intubate if we have not done so already, and we start chest compressions. We need to coordinate the positive pressure ventilations at 100% oxygen and consider an ECG monitor to determine how effective our intubated positive pressure ventilation is in increasing the heart rate of the baby. This chart shows the different weights and gestational ages for the ET tube sizes and the suction catheter sizes if we have to suction the gastric contents or air from the stomach. So for a baby that is below 1,000 grams or is below 28 weeks, we use a 2.5 millimeter endotracheal tube, and if we have to suction the contents or air out of the abdomen, we will use a suction catheter of either a 5 French or a 6 French. If the baby is 1,000 grams to 2,000 grams or 28 weeks to 34 weeks, we will use a 3 millimeter diameter endotracheal tube and a suction cath of a 6 French or an 8 French. Any baby greater than 2,000 grams or greater than 34 weeks, we will use a 3.5 millimeter in diameter endotracheal tube and a suction catheter of an 1/8 French. When administering chest compressions, we need to depress the sternum approximately 1/3 of the anterior-posterior diameter of the chest. The compression rate is 90 per minute. 3 rapid compressions and 1 ventilation needs to happen every 2 seconds. So when we were given positive pressure ventilation, it sounded like a tango. Breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. But when we're coordinating chest compressions and ventilations, it will be more like 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. At this point, we can use 100% oxygenation during the compressions. Previously, we didn't want the baby to become hypoxic, or we didn't want to risk a pneumothorax, but at this point, the baby is not doing well, and we need to get that oxygen saturation up as quickly as possible. We need to check the heart rate after 60 seconds of coordinated chest compressions.
Okay, this baby is not breathing. We're going to start bag mask ventilating. Okay. Could you assess heart rate, please?
Oh, heart rate's down. It's less than 60.
We're going to start chest compressions on the baby.
I'm starting chest compressions. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in.
The two-thumb technique places the thumbs on the lower third of the sternum and supports the back with encircling fingers. Thumbs can be side by side or one over the other.
Okay, could you reassess heart rate?
2 and 3 and breathe in. It's still less than 60.
Okay, we're going to have to intubate this baby.
Okay.
During compressions, 30 breaths and 90 compressions per minute equal 120 events per minute. Compression depth is 1/3 the anterior-posterior diameter of the chest.
Okay, see the vocal cords? Tube is through the cords. Sell it.
When resuscitation starts with less than 100% oxygen, supplemental oxygen up to 100% should be administered if there is no appreciable improvement within 90 seconds following birth.
Oh, and the heart rate's coming up.
Good.
It's above 80.
It's above 80. Okay, well, we can hold off on compressions, and I'll just continue to ventilate the baby. Could you reassess heart rate?
Heart rate's over 100, and the baby's beginning to breathe on his own.
Good.
Intubation may be needed for tracheal suctioning with meconium-stained fluid. You may also need to intubate if face mask ventilation is ineffective, if prolonged positive pressure ventilation is needed, to secure the airway and expand the lungs fully during chest compressions, or to administer medication directly into the trachea while IV access is being obtained.
Okay, baby's still apneic. I'm going to go ahead and bag mask ventilate. Okay.
Even when a baby is critically ill, it is important to follow the initial steps and initiate positive pressure ventilation. A person experienced in endotracheal intubation should be immediately available to assist at every delivery.
Moving good air bilaterally. We've got a good seal. We're still seeing good chest movement, but the heart rate feels low. It feels about 20, but I think we're going to need to start compressions. Okay. 1 and 2 and 3 and breathe in. 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 I think it's been about 30 seconds. Breathe in. I'm going to recheck.
Endotracheal intubation may be necessary when bag and mask ventilation is prolonged or ineffective, to better coordinate chest compressions with ventilation, or to administer epinephrine while venous access is established.
I think we're going to need to go ahead and intubate the baby.
Okay, yeah, heart rate's still about 20.
1 and 2
How
and
can I
3
help?
and
We're about ready to go ahead and intubate.
breathe in.
Okay.
1 and 2
Is
and
it-
3
Get
and
equipment.
breathe in. 1 and 2 and 3 and
laryngoscope.
breathe in. 1 and 2 and 3
We have a
and breathe in.
3-5
1 and 2
endotracheal
and 3
tube.
Okay.
and breathe in. 1 and 2 and 3 and breathe in.
Okay, hold
1 and
compressions.
2
We're
and
gonna go
3
ahead
and
and
breathe in.
Stabilize the head in a slightly extended position and deliver free flow oxygen. As you insert the laryngoscope, you can see the posterior wall of the hypopharynx. Elevate the laryngoscope slightly and you can see the epiglottis and glottis come into view. However, if you insert the laryngoscope deeper, you see the opening of the esophagus. If the laryngoscope is to the left or right of the midline, you can see only part of the glottis. Insert the laryngoscope to the proper depth in the midline and the epiglottis comes into view, serving as your landmark. At that point, lift the blade of the laryngoscope upward and away so that the vocal cords come fully into view. Sometimes pressure over the larynx will help visualize the glottis. Insert the endotracheal tube through the vocal cords to the appropriate guideline. Remove the laryngoscope while holding the tube firmly against the palate.
Gonna ventilate. Okay, I'm seeing good chest movement. I'm seeing good
The primary signs of correct endotracheal tube placement are increasing heart rate and color change in a CO2 detector.
And I hear nothing over the stomach. Yeah.
The entire procedure ideally should take no longer than 20 seconds.
It's still low.
okay, let's resume chest compressions.
Okay. 1 and 2 and 3 and breathe.
The laryngeal mask airway is an alternative to provide positive pressure ventilation when bag and mask ventilation is unsuccessful or intubation is not possible. First, inspect the device and test the mask by inflating it with 4 mL of air. Then remove the air completely. Position the baby's head in the sniffing position. Hold the device like a pen with your index finger at the junction of the cuff and the tube. Open the baby's mouth and press the tip of the mask upward against the palate with the index finger, making sure the mask does not curl backwards on itself. Advance the mask into the hypopharynx until resistance is felt when the opening covers the larynx. Stabilize the tube with the free hand while removing the index finger. Inflate the mask with 2 to 4 mL of air to achieve a seal. Do not hold the tube during inflation, as the device may move slightly outward. Attach the resuscitation bag and begin positive pressure ventilation to confirm placement. An end-tidal carbon dioxide detector can be used, and the laryngeal mask airway can be secured with tape or another securing device. The airway may be removed electively after deflating the balloon, or the baby may cough it out spontaneously.
So as a quick review before we get into the medications, I'd like to go over what we've done so far. So we've administered positive pressure ventilation, we've monitored the SpO2, and the heart rate is still below 100. So we're going to make sure that our chest is moving, that our ventilations are corrected if needed, and we may consider an ET tube placement or a laryngeal tube in the event that our Mr. SOPA did not correct the positive pressure ventilation. If the positive pressure ventilation has been adequate, but the heart rate is still dropping below 100, that is when we will consider an ET tube or a laryngeal tube placement. However, if the ventilations are moving the chest and seem to be adequate, we can continue to use positive pressure ventilation via the flow inflating bag. Then we saw in the videos that after we continued the positive pressure ventilation via the bag, that the heart rate continued to drop and it dropped below 60 beats per minute. We want to go ahead and start chest compressions and absolutely intubate at this point if it hasn't been done already. This is where we can set the blender up to 100% oxygen, and we need to consider placing an ECG monitor to see the effectiveness of our intubated positive pressure ventilation. We've chosen the right size ET tube and the correct suction catheter. Once we start compressions, we're doing it at 1/3 of the anterior posterior diameter of the chest. Chest compression rate is at 90 beats per minute. We are compressing rapidly 3 times, followed by 1 ventilation, and that should occur within 2 seconds. We use the count of 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. We have switched our blender up to 100% oxygen during compressions, and we check our heart rate after 60 seconds of coordinated chest compressions and ventilations. Now we move on to IV epinephrine if the heart rate continues to stay under 60 beats per minute. At this point, we may consider other reasons that the heart rate has not responded to the positive pressure ventilation. It may be some type of hypovolemia, maybe blood loss, fluid loss, and we may even need to consider a pneumothorax. A pneumothorax is common in preterm babies because of the overexpansion of the lungs. So what medications are we going to consider? Medications are indicated if the baby's heart rate stays below 60 beats per minute after at least 30 seconds of positive pressure ventilation that inflates the baby's lungs, and another 60 seconds of chest compressions coordinated with positive pressure ventilations using 100% oxygen. So if the baby's heart rate has not responded to these two things, we will consider using IV epinephrine. It is not indicated before you have established ventilation that is effectively inflating the lungs. Remember, ventilations are the primary component of neonatal resuscitation. We only use 1 to 10,000 epinephrine preparation, which will equal 0.1 milligram per milliliter. We can use intravenous or intraosseous, which is the preferred route. We give it rapidly. We use a 1 ml syringe, and we clearly label the syringe with epinephrine IV. We can give the IV every 3 to 5 minutes. If we use the endotracheal tube, it is less effective. We will want to use a 3 to 5 milliliter syringe and clearly mark epinephrine ET tube only, because of course it will be larger doses. IV and intraosseous doses will be from 0.1 to 0.3 milliliters per kilogram with a 0.5 to 1 milliliter flush of normal saline. The endotracheal tube doses will be 0.5 to 1 milliliters per kilogram, so you can see it is considerably a larger dose. It will be followed by positive pressure ventilations to distribute. This dose is only recommended for the ET tube. Do not give this amount of epinephrine via the IV or the intraosseous. We also may consider volume expanders. The types we'll consider first are crystalloid fluids. We need 0.9% normal saline at 10 mils per kilogram for the first dose, and if no improvement after the first dose, we can give another additional 10 milliliters per kilogram. Any further doses are only considered if the baby has experienced extreme blood loss. And if so, this would be given via a 30 to 60 milliliter syringe, and it would be given over a time frame of 5 to 10 minutes. We also could possibly give red blood cells, and the doses would be the same. We would give 10 mils per kilogram for the first dose, and if no improvement after the first dose, we would give another 10 mils per kilogram for the second dose, and if any further doses were needed, which would only be considered in extreme blood loss cases, it would be given through a 30 to 60 milliliter syringe over a 5 to 10 minute frame. Both volume expanders and medications may be given via an emergency umbilical venous catheter or by an intraosseous needle, usually on the flat surface of the lower leg of the infant. So here is the smiley face we discussed way back in section 1. The two umbilical arteries are up here, and the umbilical vein is down here. Now, if this were on the baby, this has been cut from the baby, but if it were on the baby's head would be down here. The umbilical vein is usually somewhere around 11 o'clock on the baby. So this is what we will use for the UVC placement.
To prepare an umbilical venous catheter for emergency medication administration, flush the catheter in three-way stopcock with normal saline. Close the stopcock to the catheter to prevent fluid loss and air entry. Prepare the skin and cord with antiseptic solution. Place an umbilical tie around the base of the cord. Pause compressions and cut the umbilical cord with sterile technique. Identify the umbilical vein as the largest of three vessels, usually located between 11 and 12 o'clock. Insert the umbilical catheter a short distance and open the stopcock. Advance the catheter while aspirating gently just until blood return is obtained. The insertion depth usually will be 2 to 4 centimeters. Hold the catheter in place as you resume compressions, clear the line and stopcock of any air, and administer epinephrine or volume expander.
Just going over, I'd like to take a look at a couple of things before we close this section. Remember, back here, everything leading up to this, I refer to it as the golden minute. So the golden minute, we must have rapid assessments made. We must anticipate any potential problems. We need to have our resuscitation equipment ready to go. And we must have our trained personnel assisting the baby. We've established that the resuscitation needs for the neonates are first to place the baby on the warmer, make sure that we're getting normal temperatures, position the airway, and ensure airway management. Use supplemental blow-by oxygen if we need to. Start positive pressure ventilations. We've just reviewed the need for intubation in certain situations. We've also reviewed cardiovascular support and chest compressions. And we finally reviewed medication. We may have to use these on newborns with congenital anomalies. This may include anomalies of the mouth, lip, tongue, palate, or neck, and these anomalies are not allowing us to achieve a tight seal with a mask, or if the visualizing of the larynx is not feasible. We also may consider these on newborns with a small mandible or a large tongue, and the face mask, ventilation, and intubation have been deemed unsuccessful. Trisomy 21 is an example, a situation where there may be a small mandible and a large tongue. And then we would also consider this mask if positive pressure ventilation provided by face mask is ineffective and intubation has been unsuccessful or not feasible. I did want to go over the mnemonic for dislodged ET tubes. This is the same as this mnemonic is the same that we have used when we've learned it in other courses. The mnemonic is DOPE. The D is for displaced endotracheal tube. The O is for obstructed. P is for pneumothorax. We discussed that. When the heart rate continues to drop down below 60%, we may have to consider that the baby is not responding due to a pneumothorax. And there is a potential for equipment failure. Remember, chest compressions are very rare. They're only indicated if the baby's heart rate remains less than 60 beats per minute after at least 30 seconds of positive pressure ventilation with chest movement. Positive pressure ventilation is generally going to do the trick. It's rare that we get down to chest compressions nor medications. These chest compressions should be applied to the lower third of the sternum, placing thumbs side by side or on top of each other. We will use the encircling hands technique where we wrap our hands around the baby's chest, placing our fingers on the baby's back for support. We're going to depress the sternum a third of the anterior posterior diameter with a compression rate of 90 per minute. We're going to give 3 compressions rapidly with 1 ventilation every 2 seconds. We're going to use the 1 and 2 and 3 and breathe count, 100% oxygen, and we're going to check the baby's heart rate after 60 seconds of coordinated chest compressions. The 3 rapid compressions and 1 ventilation will make for 120 events. That would be 90 compressions and 30 ventilations
Per minute.
This is what the algorithm alone looks like. I will have this on the monitor for you, along with all of the additions that I put in for you to refer to. Finally, what we need to do, we need to ask ourselves, how did the resuscitation go? These are the 10 debriefing key behavior skills that you will need to know during and post resuscitation. You need to know your environment. You need to know where the supplies are and where the equipment is. We need to use all available information that we get pre-resuscitation. We need to anticipate and plan. We need to clearly identify a team leader. And we need to communicate effectively. We also need to consider delegating the workload optimally, know what staff members are trained on what skills. We need to allocate our attention wisely, making sure that we are picking up on cues from the baby. We need to use available resources. If we need more people, get more people. If we need more equipment, get more equipment. We need to know when to ask for additional help, and we need to always maintain professional behavior. Remember, the mother is right there. Potentially, family members are right there. So we always need to maintain professional behavior for these resuscitations and inform the mother and the family of everything that we're doing as we're doing it. So this is the end of the left side of the algorithm. In the next few sections, we will discuss the right side of the algorithm, if the baby is breathing but not efficiently, or if there's persistent cyanosis, and what to do. We will also put it all together and show a megacode and review the care for preterm infants, and that should wrap up the online course.